Hi, everyone. My name is Carlos Chiattone. I'm a professor of medicine at Santa Casa Medical School in São Paulo, Brazil. And it's my great pleasure to be here to present some data, new data of angioimmunoblastic T-cell lymphoma. First of all, I would like to thank the organizers for inviting me. Let's move on. This, you can see my disclosures. This is my agenda. I will allude on epidemiology, biology, and clinical data. I will talk to you on the frontline treatment, on relapse refractory patients, and a little bit on what I think on the future directions. Well, it's always interesting to start since the beginning. And this was the first publication from the Rappaport group in 1974 on one disease, new disease, that called angioimmunoblastic lymphadenopathy with dysproteinemia. As you can see, they have a lot of doubts on this entity, but they thought that this was a new disease like lymphoma. In the end of the comments, they don't believe at that time that this was a neoplastic disease. They allude on the clinical presentation. It was an elderly disease with a lot of constitutional symptoms, generalized lymphonodomegaly, with infections and autoimmune present or in the diagnosed differential with dysproteinemia, and the biopsy, as I said before, didn't suggest to them at that time neoplastic disease. As you know, we have some good progression recently to characterize the different subtypes of T-cell lymphoma. This difficult is why T-cell is a much complex cell, and different from the B-cell lymphoma, we have difficulties to discover and to understand the biology of this disease. As you know, recently we have two new classification of lymphoproliferative disease, one an international consensus, and the other is the AGOO 50 edition. For my opinion, the main important new data that we have in this both classification is to put together the lymphomas, the subtypes of T-cell lymphomas in the same, under the same name, and which was that the subtypes that have the origin in the T-cell helper from the follicular center. That is a very special cell with a big importance in the development of B cell in the central, the follicular center. And they try, this is just one study made by Philippe Goulart from France and his group, showing that ALTL, angioimmunoblastic T-cell lymphoma, and the other peripheral T-cell lymphoma, that have the same origin, the same cell. They share a lot of characters, not just a clinical one, as you can see here in this slide, but in the biology of this lymphoma. So the conclusion is that the TFH phenotype share with the AITL not only the phenotype features, but also similar clinical features, genetic events, and molecular signatures. This, for me, is the most important change in the new classification, in the most new classification. So you can see here the international consensus and the new WHO classification. They have some difference in the name, but this means follicular helper T-cell lymphoma that they can show three different subtypes. The angioimmunoblastic, but two others much less frequent. Here you have the classical organogram of the T and K cell lymphoma, and now in the group of nodal, you have follicular helper T cell lymphoma that, as I said before, you can have in this group three different subgroups, but with the same cell of origin. Here is just a epidemiological data, an old one, but a very important one made by Julie Volse and people from Nebraska. And you can see here the frequency of the different subtypes of peripheral T-cell lymphoma. And as you can see here, for instance, the angioimmunoblastic has a different frequency in North America, Europe, and Asia. They didn't have at that time the data from Latin America. And as you can see here, this subtype of lymphoma is much more frequent in Europe than in the US. Here you have a consortium just created recently that joined the T-cell International Project, the Brazilian T-cell Project, and the data from the GEL. Here you can see here the data that we presented in the last ASH meeting as an oral presentation. And you can see here, talking about epidemiology, the difference that we have in the frequency of the different subtypes in Latin America than in Europe and North America. And you can see here what it's our subject today, the angioimmunoblastic lymphoma. In the total group joined by these three registry, we can see that angioimmunoblastic lymphoma accounts just by 6% of the case. When you see in this different registry, we see that in Brazil you have a little bit more, 10%, but even so, it's much less than Europe and the US. Here you have some data, clinical data, pathological features, and age and stage. The nodal T-cell lymphoma with T-cell helper follicular phenotype, is a little different from the other lymphoma. Although they have lymphadenopathy, this lymphadenopathy is normally disseminated and is small size. Frequently, you have a cutaneous rash, a systemic symptoms, hepatosplenomegaly, polyclonal hypergamma-globulinemia, pleural effusions, arthritis, and immune dysregulation. So we need to perform at the beginning to different from inflammatory, autoimmune, and viral etiology. This is very frequently, these patients when came to the hematologist have already been seen by clinicians and rheumatologists and the infectologists. The pathologist, I will see a little bit later for you, but it's necessary to express two or more T follicular helper antigens, as you can see here. And in the last column, you can see that the age, it's over the age of a PTCL, NOS, and the ALK also. The mid-age here is 65 years old. I will show you a little bit later on. These are some data from Elaine Jaffe, and you can see here some cell very similar to Hodgkin cells, EBV positive. You have proeminent endothelial venules. You have CD21 expanded, showing dendritic cells, and you can see in most of the cases EBV positive by hybridization. Here you have the genes frequently present in the AITL, and you can see ROA that it's specific for this disease. You can see IDH2 that is also specific for this disease, but you have also TED and DNMT3A present in these patients. I always like to show this slide comparing in general how peripheral T-cell lymphoma and diffuse large B-cell lymphoma presents. And you can see here the difference in the stages. The peripheral T-cell have more frequently advanced stage. The symptoms are more frequently. The bone marrow is frequently more involved than B-cell lymphoma, and the skin lesions is much more frequently. This is cartoon to show you the most common clinical manifestation, lymphadenopathy with these characteristics that I said to you, skin rash, splenomegaly, eosinophilia, leukocytoclastic vasculitis that sometimes open the disease, opportunistic infections, arthritis, hepatomegaly, pleural effusion. Here is one very important survey on more than almost 300 cases from the international T-cell lymphoma. And here you can see some of the clinical and lab manifestation. You can see here how old are these patients, how advanced are, and so on. And here it's interesting that you can see the 5-year overall survival is 45%, and the progression-free survival 38%. Here you have interesting when you compare the Julie Vos in 2008 and now this data from Ranjana Advani in some years ago, you can see that they progress in the outcome was not so improved at that time. Here is the timeline of the treatment of ATL, but it's also for all peripheral T-cell lymphoma. The diagnosis, you choose some CHOP backbone treatment. If these patients have a good partial, at least a good partial remission, you go to autologous for consolidation, but most of the patients relapsed after even the consolidation. This is the Echelon study, is the first study, as you know, that showed a comparison with CHOP or backbone CHOP. This is a trial that was designed in Europe, asking by the European regulatory to include a lot of patients, at least 3/4 of patients with anaplastic large cell lymphoma. And this is, I think, the main problem of this study, that most of the cases involved are anaplastic large cell lymphoma. You have your other subtypes also, but some of them in a small number. This was the study design, comparing the conventional arm, CHOP, with the experimental arm, CHOP without vincristine, CHP, plus brentuximab vedotin. Here you can see advantage in the BV CHP over the CHOP. And now recently we have an update of 5 years of these patients. Here you have the comparison of BV and CHOP, and the conclusion is this Echelon 2 is the first prospective trial in PTCL to show overall survival benefit over CHOP. This BV-CHP is approved in different parts of the world with different indications. Related to the consolidation of transplant, autologous transplant, after the initial treatment, there is no clear evidence in the literature, but you can see here some trials showing that it's good, and the other that it's not benefit. There is not benefit, but in the end of the day, although there is no clear evidence, most consider transplant, as NCCN suggests. Here's the NCCN data for first-line therapy for ATL, together other groups. The preference regime, just for in alphabetic order, is the BV, CHP, CHOP, and EPOC. Here you have, in terms of relapse or progression, you know that relapse or progression in peripheral T-cell lymphoma is some used to say that this is the most difficult situation among all the different lymphoproliferative disease. Here is how is the therapeutic plan for peripheral T-cell lymphoma relapse or refractory. If the patient is candidate for salvage with allo, they go through this way. Otherwise, they should use sequential drugs. And here, just very quick, you can see that in this situation, peripheral T-cell lymphoma, just the allo has importance. You can see here something important that you can see in the literature, showing that perhaps the patients with completely response, that is what we look for, have the same result when submit or through allotransplant, compare with partial remission. Sure. And the CI-BMTR showing the same some years ago. So what I would like to show you, this is my personal opinion, that when you put the patients in the sequential drug, is not necessarily a palliative road. You can have also good response nowadays, showing in the literature that patients using new drugs can have a good partial remission or even complete remission and go to the other branch, to the allotransplant. These are a cartoon showing the new drugs that I have no time to allude on each one, but I want to show that some slides showing that brentuximab and two inhibitor of histone deacetylase and a PI3K inhibitor have almost the same response, but pay attention, pralatrexate is not indicated to these patients anymore. Here you have the options for the second line with intent of transplant and without intent of transplant. With intent of transplant, what you can see here, besides all the chemo possibilities, you have the new drugs. And when no indication for proceeding to transplant, the preferable regimens for sure, clinical trial, but just new drugs are put in this side. Here you can see the new drugs, and I can call the attention on the availability of this drug availability in Brazil. We have rituximab vedotin and belinostat. To finish, another point, almost 19% of this group of lymphomas have a relationship with EBV. And what is interesting, most of the EBV infection were in the B cells and not in the T cells. But nowadays, there is a publication and a trial ongoing, that try to focus in the EBV, using a way to sensitizing EBV cells with a new inhibitor, and then after that exposing the structures of the virus. They use a cytotox antiviral drug. And these are the results in this first trial, 1B2, and you can see that these patients with very bad prognosis have, in this small number of patients for sure, they have 30 to 50% of a response, and you can see much over than the other options. So to finish, I have to say some take-home message. First, PTCL treatment should be as much as possible subtype specific. Mutational profile should be the focus to choose second-line therapy. PTCL with this T-cell follicular helper phenotype as angioimmunoblastic lymphoma arise in an inflammatory state and have a frequently autoimmune manifestation. Novel therapies in second line may improve outcomes, and you are seeing that, including being a bridge for an allo transplant, as I said before. And in the end, we are anxiously waiting for new drugs combination. So I'm grateful for your kind attention, and thank you again.
Well, thank you very much, Dr. Chiattone. This was an outstanding presentation, and we have time for one or two questions, I think. One is that we saw that there is some difference in the incidence of angioimmunoblastic T-cell lymphoma in Latin American ones. What do you think is why do you think this is have this difference? Only 6% here in Latin America and 18 or 20% in Europe. This is a biological issue or is because of pathology?
We don't have a clear reason for that. Different from the NK nasal type and the ATL, that we have a clear genetic and infectious reasons. For that, we don't have a clear data. I cannot exclude some bias in the diagnosis to include the patients in the registry. In the other side, could be a relative inferior percentage, because we have a much more two subtypes of the peripheral T-cell lymphoma with a high percentage. But I think it's time to try to investigate some biological reason.
Perfect. And Dr. Malaga says that if you have any comments about cyclosporine in relapsed refractory angioimmunoblastic T-cell lymphoma.
Yes, well, we have several different options, but with not clear data in the literature. As this disease have inflammatory environment and frequently an autoimmune manifestation, cyclosporine could be an option for these patients, because it's interesting. This is really a other peripheral T-cell lymphoma. So we have a good advanced understand the cell of origin. So I think combination of these different drugs, hypomethylants and inhibitors of DHAC, and the other drugs also. Another drug is lenalidomide that sometimes work in these patients, but the data are anecdotal.
Yes, and we would like your final comment about, do you recommend the use of Echelon 2, like brentuximab CHP, in this pathology with the data that we have? Like brentuximab CHP in this pathology with the data that we have?
Yeah, this is a tricky question. There is no data for that. Sometimes you have a clonal infection with EBV in the B cells. As far as I know, we had in the past some trials trying to do that, but there is no evidence to do that. Just if the patients have some autoimmune manifestation, autoimmune anemia, or IPT. So in this case, you can use rituximab.